We have 5 cases for today, and we'll start with the first one, which is Medicine 5 on a trail down Chapel Hill.
Morning to everyone present here. I'll be presenting on behalf of Medicine 5, Trail Down Chapel Hill. Presenting a 61-year-old gentleman who presented to us with history of fever since the past 1.5 months. The fever was low grade with evening rise of temperature. It was associated with chills and night sweats, relieved with paracetamol, and he had the fever 2 times per day. It was associated with nasal discharge, which was blood tinged, and yellowish with blood tinged. There were 2 episodes of epistaxis. He also had cough for 1.5 months. There was dry cough. There was no associated hemoptysis. For the past 15 days, he had leg ulcers. They started as like hyperpigmented lesions, then developed to become blisters which ruptured and then ulcerated and healed by crusting. He had oral ulcers which were present over the tongue and the lip, and it was painful such that he was only able to take liquid food. He was a recently diagnosed diabetic when he presented to a local hospital with a current illness. He has no, and he was admitted twice for this current symptomatology that he had, and he was treated as pneumonia outside with no resolution of his symptoms. Moving on to examination. On examination, his vitals was 112 beats per minute regular. BP was 110 by 70 millimeters of mercury. He was breathing at 36 times per minute, cycles per minute. His temperature was 100 degrees. He was saturating 93% on room air and not using his axillary muscles of respiration, though he was tachypneic. There was pallor, bilateral pitting pedal edema up to the ankle. There was no ictus clubbing, sinuses, or generalized lymphadenopathy. Oral cavity examination showed bilateral lateral border of the tongue, deep ulcers, curdy white precipitate over the tongue, and also ulcer was present in the inner aspect of the lower lip. Bilateral lower limbs, he had lesions in multiple stages of evolution. Some were initial hyperpigmented state, some formed blisters, and some had a bloody use, and some had formed crusted with healed by crusting. And nasal cavity, there was crusting and bleeding spots noted in the nasal cavity. There was no polyp noted. A rest of the systemic examination, only abdominal system had a positive finding of a palpable liver. Trough space was resonant. Shifting dullness was present. So summarizing, a 61-year-old gentleman who came with a 1.5 months history of fever, blood-tinged nasal discharge epistaxis, dry cough, leg ulcers, oral ulcers with a recently diagnosed diabetic, with examination findings of pallor, oral ulcers, and multiple ulcerative lesions in multiple stages of evolution in the lower limbs, nasal cavity having crusting and bleeding spot. So what are your, can everyone contribute to the differentials of this case? Thank you. So as most of you have mentioned it, so our differentials also initially given a gentleman with a multi-system involvement and with preserved weight and appetite, we are considering predominantly vasculitides, of which the predominant one being considered was granulomatosis with polyangiitis. The other differentials were eosinophilic granulomatosis with polyangiitis and microscopic polyangiitis. We also considered, because of the fever, cough, we considered tuberculosis as well. So moving on to the investigations, the patient was noted to have anemia. He was also noted to have a worsening renal function trend in the form of increased creatinine, and there was also associated the RBCs in the urine with the protein leak and blood being positive. So his LFT and renal function tests were normal. We did a phase contrast microscopy for the hematuria that he had, but we got only predominantly isomorphic RBCs. However, his UP by UC was elevated, the normal being 0.21. His UP by UC ratio was elevated 1.1. Since the patient had a high total count of 33,800, we wanted to rule out infection. So we culture, blood cultures, and wanted to rule out tuberculosis. And infective etiologies were ruled out. Infective endocarditis was also a differential considered, and echo was done, but there was no vegetation seen. So we went on to the vasculitic workup for the patient, and he was noted to have anti-PR3 highly elevated, more than 200 units per ml. And since the patient had the rapidly worsening renal function, we went ahead with a renal biopsy. And he was noted to have a post-immune necrotizing glomerulonephritis involving 43% of the glomeruli. And the skin biopsy was taken from the ulcerative lesions, which showed a small vessel vasculitis with surface ulcerations and few ill-defined granulomas from the skin biopsy. The cross-sectional imaging that was done in view of the patient's cough and tachypnea showed multiple nodular lesions along with bilateral effusions, but predominantly the point I wanted to show here is the multiple nodular lesions. So according to the 2022 ACR EULAR criteria for the granulomatosis with polyangiitis, our patient successfully criteria because he had nasal involvement, he had bloody discharge, ulcers, and crusting. So that gave him 3 points. And then he also had a positive anti-PR3 antibodies that gave him plus 5 points. There were pulmonary nodules, which gave him another 2 points. That comes to a cumulative of 10. Granulomas were seen on the biopsy of the skin, so that gives another 12 points. So actually, if a score of 5 is sufficient in order to classify the person as a granulomatosis with polyangiitis. So I just wanted to briefly mention on the approach to vasculitis. So here I just wanted to address 5 questions. So when a patient presents with a multi-system involvement when we are thinking of vasculitis, first question to think is this a condition that could mimic the presentation of a vasculitis? And then is there an underlying cause for the vasculitis? What is the extent of the vasculitis? How do I confirm the diagnosis and what specific type of vasculitis is it? So is this a condition that could mimic the presentation of vasculitis? Is this something else? So if you've seen on the slide for the diagnostic criteria here, they mentioned that alternate diagnosis mimicking vasculitis should be excluded prior to applying the criteria. So what is the presentations or the diagnosis that could mimic vasculitis is infections such as tuberculosis, infective endocarditis, thrombotic conditions like APLA, sickle cell disease, thrombocytopenic purpura, embolization from an atrial myxoma or cholesteromas, or non-inflammatory vessel wall disorders like a fibromuscular dysplasia amyloidosis, vitamin C deficiency, scurvy, or an ergot-induced vasospasm. Then the next thing to consider is then underlying cause for our vasculitis per se. So we need to look for other inflammatory diseases such as rheumatoid vasculitis associated with SLE, Sjogren's, inflammatory bowel disease, and sarcoidosis. There could be other infectious disease like hepatitis B and C, or HIV, or TB, or syphilis, which could be an underlying condition that could trigger a vasculitis. The neoplasia like hematological malignancies, which are either myeloproliferative or lymphoproliferative, and there could also be other solid organ tumors that could secondarily trigger vasculitis. Some of the causes of drug-induced vasculitis will be hydralazine, propylthiouracil, and Montelukast. So next, one needs to know what is the extent of the vasculitis. Why? Because it can give clues to specific vascular type that is involved, or there can be an organ-threatening involvement which calls for a more aggressive and a quicker treatment. So now, our patient actually, since he had multiple evidence of GPA with the positive anti-PR3 and the worsening creatinine. We even like one day prior to the renal biopsy, we had gone ahead and given him the steroid pulse because of the strong clinical evidence for a GP. So requires a thorough history, a detailed physical examination, few simple investigations, which I'll be mentioning later. Here's just a distribution of some of the small vessel anchor associated vasculitis, where we can see in GPA predominantly we have pulmonary, ENT, and renal involvement, which is in GPA. The microscopic polyangiitis has more predominant kidney involvement. However, its involvement in the pulmonary and the ENT involvements are less. And eGPA or Church-Strauss has predominantly pulmonary and neurological involvement. And it has far lesser amount of people being affected with the renal involvement. So next, how do I confirm the diagnosis of vasculitis? We need a tissue biopsy. So as we saw in our patient, we had tissues from one, the kidney, and the other is the skin. The site to be biopsied depends upon the clinical presentation. So for example, in our patient, we could have just done the kidney biopsy, and that would have also sufficed to make the diagnosis, and the skin might not have been needed. But the skin was done earlier. So the common favorite sites include skin, kidney, temporal, nasal mucosa, lung, sural nerve, and testes. In a multi-system involvement, we must choose the biopsy site depending on the likelihood of affecting the treatment decisions. Like in our patient, if I had to choose between the skin and the renal, I would go for the renal biopsy. So finally, what specific type of vasculitis is this? So according to the Chapel criteria, the vasculitis differentiated as large vessel vasculitis, medium vessel vasculitis, then immune complex small vessel vasculitis, and then anchor associated vasculitis. So here's a simple algorithm. When a patient presents with a multi-system involvement, when we are suspecting vasculitic syndrome, we could clinically with these features, we could have suspicion of small vessel, medium vessel, or large vessel. So somebody present with purpura, ecchymosis, vesicles and bulla, hematuria or hemoptysis, splinter hemorrhages, and uveitis or epichlorite, we can suspect a small vessel vasculitis. Those with nodules, lividoreticularis, mononeuritis multiplex, gangrene of digits, and microaneurysms, medium vessel vasculitis can be suspected. Those with limb claudication, missing pulses, bruits, aortic dilatation, asymmetric BPs, we can suspect a large vessel vasculitis. So in the small vasculitis, HSP, Henoch-Schönlein purpura will be marked by arthralgias, abdominal pain, palpable purpura in the lower limbs, and bloody diarrhea can be present. In granulomatosis with polyangiitis, as we saw in this patient, they can have sinusitis, oral ulcers, hemoptysis, subglottic tracheal endobronchial stenosis, and predominant renal involvement can be. And eosinophilic granulomatosis with polyangiitis can have asthma, atopy, pulmonary infiltrates, neuropathy, and eosinophilia. Then looking at the medium vessel vasculitis, Kawasaki is predominantly in the children where they can have fever for more than 5 days, cervical lymphadenopathy, rashes, mucositis, and more than the second week of their illness, they can develop a coronary artery aneurysm. Then in polyarteritis nodosa, they can have nodules, neuropathy, hypertension, renal involvement, and testicular pain can be present. And next, we know the large vessel vasculitis of giant cell arteritis and Takayama arteritis.
Ahikam, can you wrap up?
So the final thing that I wanted to mention was the important investigations to consider during the initial evaluation of a suspected vasculitis. So we can send to rule out the mimics and the secondary causes of vasculitis, blood cultures, echocardiogram, hepatitis bloodborne virus screen can be done. Anti-APLA ANAs can be sent. To assess the extent, we can do a simple urine dipstick and a microscopy, chest X-ray, nerve conduction test can be done. Biopsy for the diagnosis of vasculitis, and to identify the specific type of vasculitis, the specific test can be sent. Thanks.
What happened to your patient?
So we gave him methylprednisolone pulse, 1 gram for 3 days. And then since he had a predominant renal involvement, we're pulsing him with rituximab. So for that, patient has been taken over by nephrology. So he's doing better. His creatinine had come down significantly.
Any questions?